Greater Birmingham. And I just want to say I'm happy you're coming, and our guest speaker is going to be introduced by Lynette Slay. But before I take my seat, please mark your calendars for September 12th, 2019, 5:30 p.m. for our meet and greet, our annual meet and greet, and that's the opportunity for you to bring friends, neighbors, co-workers, so that they can meet us and we can tell them what the league is all about. And without taking up any further time, I present to you Lynette Slay, and now we have a question from Judge.
Where is the meet and greet?
Oh, I'm sorry. The meet and greet is at our usual place, City Club. We changed the name to City Club, downtown Birmingham, 5:30 p.m. to 7:30. Lynette?
I'd also like to welcome all of you who came tonight. And when we have a program with the League of Women Voters, we try to link it to a national league position or ongoing league research. So before we talk specifically about our state, I wanted to share with you some of the history that the League of Women Voters of the United States has done on research and study and lobbying on health care. So the League's position is that every person in the United States should have access to affordable health care, a basic level of quality health care, and, to speak to our program tonight, there should be an equitable distribution of services. The League has also been very adamant that this is not just physical health, but also mental health. It should be available to all. And we believe that it could be more equitably allocated by sending medical services and resources to underserved areas, which is also going to be on point for tonight's discussion. There's much more, and if you just want to delve into league business, this is the book to go to. And this is freshly updated to include what we did in the last congressional session and what we hope to accomplish between now and 2021. So having said that, we are fortunate indeed to have someone to talk to us tonight that has seen the big picture in a dense urban area like Birmingham, and is now bringing health care to a community of 4,000 in a distinctly rural part of Alabama. Curtis James and his spouse and partner in this enterprise, Jolene, are here to talk with us, and he is the former president and CEO of St. Vincent's. And he was the CFO there for 22 years. Then he moved up to be CEO for 10 years. And during the time that Curtis was at St. Vincent's, they had phenomenal growth. And so he can reach back to this very complicated, intricate system and build on that for what he's doing in a completely new part of the state for us. He got his BS from the University of West Alabama, got his MS from Stanford. And in the last few months, I would say, he was approached to build a 29-bed acute care facility in one of our underserved areas of the state. So he has graciously agreed to fit us into his schedule, and he's going to talk about how that happened, what the challenges were perhaps at St. Vincent's, how we can translate that today, what Medicaid might look like, pros and cons, and I've already told him that the League is famous for asking questions. So would you help me welcome both Curtis and Jolene James?
Thank you very much, Leonette. And thanks for having me speak with you this evening. In doing the research about what is really happening in rural health care in Alabama, I learned a lot. I've been in healthcare for 32 years, but I learned a lot of new statistics that was in the research, and I'm going to share some of those with you tonight and be open to ask questions. Leonette talked about St. Vincent's. St. Vincent's had two large urban hospitals, St. Vincent's Birmingham and St. Vincent's East, but we had two rural hospitals, one in Blount County and one in St. Clair. And I always loved going to those board meetings at those rural facilities. First thing I would do is walk into that boardroom, and it was all local board members. And the first thing they would ask me is, "Hey Curtis, how's our hospital doing?" And I thought it might be St. Vincent's Hospital, but I was glad that they adopted it as their hospital, because that's really the way you make a difference in rural health care. If it was ours or our companies or whatever, that really is not what this is about. If you can get dedicated people in that community, in a rural community, to come up and say to you, "Hey, this is what happened at our hospital last week," then you've got the best of both worlds. You've got the support you need from a community standpoint and a leadership standpoint in that community. But I just wanted to share that with you before we talk about rural health care challenges and hospital challenges specifically in the state of Alabama. To do that, let's just look and see how rural Alabama really is. I think we know, but the statistics tell us that there are really 55 counties out of the 67 counties in Alabama that are considered rural. So there are only 12 of the counties that the statistics say that are really urban counties. And in April of 2019, some of the statistics about the delivery of health care in those 55 counties, there are 48 rural hospitals, and obviously in those 55 counties. There are 5 critical access hospitals, and that's a new designation, but it is a designation that says if there's no other hospital within 35 miles of where a hospital is, you can qualify and ask the federal government to start reimbursing you as a 25-bed hospital and as a critical access, because there's no other hospital 35 miles away. Now in Alabama, we've got a lot of them real close, and we'll talk about why that occurred. There's 112 rural health clinics, 102 federally qualified FQHC centers, as they call those. But if you look at Alabama compared to the United States, you'll find in the population of 5 counties, they're 23% of the population, 1.1 million in the rural areas in the 55 counties. And the 12 counties, there's that difference of about 3.7 million. But the United States as a whole is only 14% rural. We know we're rural. The mayor of the little town of Thomasville I'll talk about, he's got a saying, because he's entertained Chinese companies coming to be in Thomasville, Alabama and all, and he has a saying, "It's cool to be rural." So he likes that, and he uses that to his advantage to bring in additional jobs and commitment in that town. This is a busy map of Alabama, but it shows all those things we just talked about. And again, there are only 5 critical access hospitals, and we'll talk about that in a moment. But those are, there's one you can see in Choctaw County to the west, down below that in Washington County, and there's some up to the right. But you can see where a lot of the rural health clinics are in the northeast of the state, and there's green dots there. It's kind of interesting to me to just look at where all these different access points, as you talked about, Leonette, where those are in Alabama. There's a lot of access points, but again, we need to look and make sure that we've analyzed the services that are being given in those access points to make sure that we understand the populations we're treating. And we'll talk about that in a moment. Talk about Alabama hospitals since 2011. There's 13 of hospitals in Alabama is closed. I think there was about 107 hospitals maybe 5 or 6 years ago in Alabama or something like that. But 13 hospitals now have closed, with 7 of those in the rural area. So we had 50 a few years ago. Now we have 48 rural hospitals. Well, those hospital closures are kind of all over the state. You can see the urban 6 hospitals that closed. I believe the one here in Jefferson County would have been Caraway at that time, since 2011. You can see some of the other rural hospital areas. The one that we're working with the mayor in Clarke County was actually closed in 2011. We're replacing that old hospital, but it's not the same, and we'll talk about that and why. If you look at some of the hospital financial facts, you'll know why they closed. 2016 data is out there, and you look on the left-hand side and you see that all hospitals in the state were running a negative margin. In other words, they were losing money at the operating level, about 6.5%. Now, they were about break even on a total margin, which means they probably had, the only thing that's different there, probably had some investment earnings, so they had some money. But then you look on the side of the rural hospitals on the right-hand side there, and you'll see that their negative financial numbers were 12% on the operating level. In other words, they were losing at that level on the operations. And then they obviously had a few earnings too, so they were negative, but 3.5. But the biggest thing on this slide is that 88% of all rural hospitals in Alabama in 2016 were already losing money. They're already in the red. And a few, maybe a year or so ago or something, a group called Navigant did a study of all rural hospitals, not just in Alabama, but all across the United States. So I wanted to really compare Alabama to some of the other states to see if we were better or worse as far as closures were concerned, and were we really at risk like some of these other states. And I can tell you in a minute, we're pretty much very at risk. But if you look at rural hospitals, they serve about 60 million Americans. So if they weren't there, those 60 million would not be served, or they'd have to travel very far away to get health care. And I can tell you in the area, you got to go 100 miles to get health care if you're going to get an MRI or something substantial. You have a cardiac issue, you're going to have to travel over 100 miles to Mobile in this case, and we'll talk about, or Montgomery, or 140 to Birmingham and so forth. There were 95 rural hospitals across 26 states that closed since 2010, all across the country. So when Navigant, the consulting group, did their analysis, they found out that nationwide there were 21% or 430 hospitals across that were at high risk of closure. But let's look at some statistics that they came up with. Now, Alabama made the top of the list. That's not good. This is not where Alabama needs to be at the top of the list, but Alabama made the top of the list. And what does it say? It says the number and percentage of rural hospitals at high risk of closure, even those 48 that are left in Alabama. Navigant said across the whole country, there are 21% of hospitals at high risk closing unless their financial situations improve. There are 34 states that have 5 or more hospitals, rural hospitals, that are in high financial risk of closure. If you look at red there, you can see there's Alabama, Mississippi, Georgia, Arkansas, Oklahoma, Kansas, and so forth. But Alabama, it says on their study, has the highest percent of rural hospitals at financial risk of closure. We're at 21 hospitals, or 50%. Now, I guess they said we had 42 at the time or whatever. But they saying that we're at the highest. We're at 50% of those hospitals are at risk. Now, they're not closed, but they're at risk of closure. But take this slide and let's look at the next slide, because rural hospitals really make a difference from an economic impact on those communities like you've never seen, and we'll talk about what that is. But if you look at the next slide, what it has here is it says, well, rural hospital community is essential across the U.S. But what percent of those really, what we would classify, or they classified as essential hospitals, are at risk? And if they were closed, they're the economic driver in most of these states. Now, Alabama's not on that top list on that one, which is probably not good either. But Montana's got 12 hospitals, 100% risk of all their hospitals, and they make they're essential in those communities for jobs. They're essential to those communities' welfare, to the treatment of those communities that are sick and need care or need diagnostics. They're essential. But you can see that Alaska, Colorado, Arizona, and so forth, but Alabama is not on this list. There's 61% that goes to the bottom of this list, and Alabama has 48%. In other words, 10 of that 21. They say if 10 of those 21 are also at risk of closing, and if those 10 close, that's going to make a major economic impact in those communities of the way they valued the numbers from those hospitals of what they were contributing to the local economy. And so just be aware, two charts going totally different directions. Alabama's at the top on one, which is not good. They're low here, but they're still saying that 10 of 21 could close, and those have a material impact on 10 rural communities. And if those close, those would be probably worse than some of the other ones, obviously. Well, what are the factors driving the rural healthcare crisis? What are they? Well, Navigant broke those down just 3, but they're major. It said, we've got a payer mix issue in some of these rural communities. Agriculture and manufacturing jobs over the past have gone away, and they recognize, now I'm not sure I agree, but they recognize that these rural communities tend to be, the people in the residents in those rural communities either tend to be very old or very young. In other words, high Medicare, young people that don't need as much health care, but they're saying that the payer mix, when you get a hospital that has, in this case they're saying 46%, and hospitals usually have 55 or 60% Medicare patients. Medicare reduces their reimbursement on 60% of your business. It's not a good thing. So they describe payer mix. So what do we need to do in Washington? Every time they start talking about cuts for the hospitals, especially in rural communities, obviously that's going to hurt even worse. Also, have you been to the hospital lately? Did you have surgery? Did you stay 3 or 4 days? No, you probably went home as an outpatient. Hospitals don't use inpatient beds very little anymore because the insurance companies are not allowing them to. They say, oh, well, you're in here for a day surgery, where before, maybe 10, 15 years ago, you may have stayed 5 days, but not today. So those beds that were so critical in the past, and all the hospitals around the country were built as inpatient facilities. I remember when St. Vincent's was 5% outpatient. We thought, man, that's a lot. But in surgery today, that number may be 80, 85% outpatient surgeries. You don't have many inpatient surgeries at all in hospitals, and you don't have stays as long. So just the fact that many rural hospitals, when they were built post-World War II, there was nothing there. They didn't have MRIs. They didn't have CAT scans. They didn't have mammography. They didn't have diagnostics. They had very little technology at all. But all it was nurses taking care of patients sick in a bed. That model is gone. It's gone. But all of the rural hospitals in Alabama today, they were built for that inpatient to come stay. So a lot of their infrastructure today is inpatient driven, and that's not the future. And it's what it was then, but they have not had the capital to replace those. And then the other thing that we just talked about, a major factor in driving rural hospital crisis is the inability to leverage innovation. Again, you were built many, many years ago. You haven't kept up because you hadn't had the capital to invest in the latest mammography machine or the latest MRI or the latest CAT scan. And you haven't had the opportunity to invest in things like electronic medical records, which now Medicare requires that now. But you don't have advanced imaging platforms. Again, you have very little, you don't have any telehealth. And that's what the young folks today are doing. Do you think they want to go sit an hour to wait for a doctor in a large waiting room? Mm-hmm. They want to get in front of their phone. Or they want to go to somewhere where telehealth, and they want to get in front of a monitor and say, I've got this rash. And they don't care if the doctor's in Colorado or California. they don't want to waste that time. So we've got generations, especially the younger generation, that says, this model's old. I don't go to a doctor. I go to a minute clinic, or I go to someone that has the technology to take care of me right then. And I want to be seen by a specialist, and I don't care where that specialist is located. So telehealth investment, rural hospitals can't make that. There's some grants out there and all, but it's very difficult to keep up with technology when you've got a large hospital, again, with a lot of inpatient beds and very little technology. So those are the major factors driving it. Well, what about just critical points along the rural healthcare policy timeline? Does any of those have any effect of where we are today? I'd say the top one that I've circled that came out in 1946, it was actually this month, August, 73 years ago, the Hill-Burton Act for building healthcare facilities around the country. The Hill-Burton Act, which Senator Hill was from Alabama, Senator Burton was from Ohio, they got together and said, let's put some federal funding together for rural communities and we'll boost the number of facilities. Well, they did that. We'll see what I think has caused some of the issues in Alabama. At that time, we'll go through that. 83, we had hospital Medicare change the way they paid people. 97, there was some rural flexibility program creating these critical access hospitals. And those critical access hospitals, again, if you're 35 miles away from another one, you can be designated if you want to. You're then limited to 25 beds, so you can't have 50 beds like in the past. You're limited to 25 beds, but Medicare will pay you cost plus. So if your costs go up, they're going to cover it. But you're kind of limited what you really can do as far as number of beds, but you don't really need those. So with 5 critical access hospitals in Alabama, that means a lot of those rural hospitals are closer than 35 miles. Is that really where we want to be? Or is that fair to the other communities? So those are some of the things that were happening in healthcare. And then you can see some of these other things, we won't go over it, but in 17, they started saying, let's introduce a bill that helps rural hospitals stay open by converting to emergency and outpatient clinics. Now there's the outpatient deal, but not many have done that because they're still trying to hold on to those inpatient beds. And so that's an issue. But let's look at the Hill-Burton Act for just one moment. Again, August 13th in 1946, 73 years ago this month, Hill-Burton came out with this. By 1975, from 46 to 1975, nearly 1/3 of all U.S. hospitals were new. And when you look at the legislation that came about after that, there were 6,800 new facilities in 4,000 communities built with Hill-Burton money. Now those things are 70 years old today. And some of those 48 hospitals are probably 50 years old or have had additions, but they started with that 50-year-old Hill-Burton hospital, and those are still around. For them to replace that today is a lot of money. It costs about, we used to use the rule of thumb of a bed because that's what you were building, but you're not building that today, but it's $1 million a bed. Now it's about $1.2 million a bed if you want to use that analogy. But let's look at Alabama because Senator Hill was from Alabama. 65 of the 67 counties got some form of Hill-Burton funding for the construction of new hospitals and healthcare facilities. So just about every county in Alabama built a new facility, 46 to 75. And a lot of those, again, are what situations we're dealing with today. And you can't maintain them. If you tried to change something or build something new, the codes today are very, very expensive. So you live in that environment, but that's not the environment of the future. Let's look at something else that's driving Alabama crisis in rural health care. There are In 62 of the 67 counties in Alabama, there's a primary care physician shortage. We won't have enough physicians. So if you use primary care and you go to the doctor, you don't necessarily have to go to the hospital, but we don't have the doctors to take care of the population in 62 of the 67 counties. There's just an overage in these 5 counties of Madison, Shelby, Pike, Coffee, and Escambia. So what did Blue Cross do? Did something good. Actually, it sounds like it. They put $3.6 million aside and said, you know, we want 60 new doctors out of UAB, primary care. We want them to go to those rural areas and serve for a little time. That's a good thing. And hopefully that will help, because there's a shortage there of doctors to see people too, okay? Well, a small list of what I would say that especially could be done with these Alabama rural hospitals. Become a Medicaid expansion state. And I know this group and other groups, Arise and all, UAB, there's a MNAT study there, and we're going to look at some of that material. We're not. I think there's only 14 in the whole country that are not Medicaid expansion. In these rural areas, you have high Medicare and high Medicaid, but they have no coverage, so they're not taking care of themselves probably, and they're not going to the hospital, and they're not going to even in some of these clinics. So expanding Medicaid would really help Alabama long term. We'll see some of the numbers about coverage and all. I'm biased, but I would partner with cities that believe in economic growth and form some type of an alliance, and that's what we've done through what's called a public-private partnership, and assist in the cost of new facilities in that community, and provide one of the 2 most important elements businesses consider when picking a new growth location. What do you think a business is looking for if they're going to invest a group out of Tuscaloosa, Sawmill, recently invested they're going to invest $190 million in this little southwest Alabama town called Thomasville, Alabama. Why do you think they would go there? What were they looking for? What were the 2 things they were looking for their employees? Education. They wanted good education because they wanted to be able to tell the employees that they got the best education in high school. The graduation rate's very high, and they've got a community college there, and education. What's the second one that we're talking about tonight? Is healthcare, right? They want to make sure that their employees' families can be taken care of in that community and not drive 100 miles. So that's very important for economic growth. And then again, we talked about this, but look for ways to deploy technology, both from an information system technology and diagnostic capability, and including telehealth capabilities that we talked about. Why do you want to become a Medicaid state in Alabama? Well, the benefits of it says that we can now insure 340,000 more adults in Alabama if we do Medicaid expansion. The rate there without health insurance dropped 35 to 16% in the expansion states. So we know that works in the expansion states that have done this. Hospitals are 84% more likely to close in non-expansion states like Alabama. That's a big number, 84% more likely to close because they don't expand into Medicaid. And then you can see that Medicaid's going to lead to early detection of these 340,000 cancer, fewer deaths, better outcomes for patients, and so forth. So the economic impact, and Dave Becker, UAB, Public Health, and the MNAD, this National Accounting Consulting Firm, said the overall impact of being a Medicaid expansion state in Alabama is $11.4 billion over 4 years. And at the same time, $316 million will be saved through higher federal match. And so what that means is Alabama will receive $9 in federal funds for every $1. That's a pretty good match that they spend indefinitely. And then there would be some taxes to offset the cost of getting involved in here, but the savings and all in revenue would be about $239 million over 4 years. That's a pretty big impact. And Senator Doug Jones came and visited this hospital that we're building in Thomasville, Alabama recently. And he walked around with us an hour. He had a forum that day. He did visit other places in Thomasville. But he spent about an hour at the hospital, and he's for Medicaid expansion. And he doesn't know that he's for health care for all yet. He said he has to do some more study, but he wants to see Medicaid expansion in Alabama. There's also a wage index deal that they're talking about that don't have any on slides. But Alabama gets like 66 cents on the dollar for a wage index that tells you how much you're going to be paid by Medicare, where California may get 140, and it's not fair. And they're treating some of the same types of diagnoses, and so one of the things that they hope to have is the wage index increase for Alabama. That would help Alabama hospitals, rural especially, receive more money. Oh, I'm going to go back one, sorry.
Why do you think that index, I mean, that might not be your area, but why would that be such a difference there?
One thing, they're using an old methodology that's been used forever. I can tell you when I was at St. Vincent's, and just talk about Medicaid in for a moment, they were using like 12-year-old data to reimburse hospitals under Medicaid. Who did it advantage? Now, St. Vincent's had neonatal nursery that had a regional neonatal nursery, and so we had some high-risk Medicaid babies there that were very expensive to take care of, but we did. But I was on a group studying, well, why is it so different? But they were using, again, 10 to 12-year-old data. And who did it favor? It's favored in certain cities in Alabama, not Birmingham. Well, maybe one in Birmingham. But it favored some of these hospitals that were looked at more like monopolies in these other cities. And they were very large hospitals and very wealthy hospitals. And that's still happening. So the wage index was the same thing national. They based it on some old data. They fought to keep it that way because the hospitals that are getting paid a lot, they fought to keep it that way. Legislation to keep it that way. But it may be changing in Alabama, which is a very good thing. Let me go back here, sorry.
Well, Chris, why are we one of the 14 that just refuses to expand Medicaid with all the facts that we've just heard?
I think the facts there, Leonette, is that they think that it's going to cost cost the state more money, or take money from one side to the other. I haven't studied that to be exact on that. But Alabama decided, with other states, and they just stuck to it. They just can't get it done. So I don't know the exact deal there, but Alabama's just stuck their head in the sand again. Okay.
We do have a fact sheet over here on the table.
That's good.
That breaks down how that cost can be covered.
That's right. Yes, and the study was well done, and it can be done, and like I said, the rise is after that, and that's good.
I don't mind saying or speculating
Yeah.
on that. I
Okay.
mean, I think the general perception about Medicaid, there's a real bias. Even though I haven't looked lately, but 51% of the babies in this state are born with Medicaid coverage. But yet there's a real bias for people on Medicaid. And I think that's the general perception.
Well, that's got to have some impact. You're correct. I think you're right. Well, are these rural hospitals really valuable? They're 48. They're all losing money. Are they have any value? Well, absolutely. In some cases, you look at this, they're the top 5 employer in 60% of the rural counties in Alabama that have a hospital. They're one of the top 5 employers. So if they're not there, all those employees are without a job. There are 11,200 on this study, and this is several years old. 11,283 Alabamians were employed by those rural hospitals. It created over $500 million in payroll benefits for those people that worked at those rural hospitals. And for every hospital job, it was creating an additional job in the local economy. They need supplies. They need a lot of things that that community is putting in that hospital. And they also say that every dollar the hospital spends or generates on revenue, they spend $2.20 in that local community. So they're absolutely valuable. But again, they're all suffering because of reimbursement issues, technology, and old facilities. Back then, and Jim is not the executive director now, but several years ago, he was touting again that the value of rural hospitals is industrial recruitment, what we just talked about. You create education well, you do education well, and you do health care, you're going to retain and attract business. And that's what this Thomasville Hospital mayor has done. So why are we building a new hospital in Thomasville with all these things going wrong? Why are we doing that? It's the right thing to do. It's the right thing to do, first of all. But you need to do it with a city that's going to recognize it's the right thing to do for their citizens. And you need to work with a healthcare partner, and what we've created is a public-private partnership. And we said to the city, you want a hospital there? Well, how are you going to help that hospital sustain itself over time? And the first few years, well, I can't do anything. But then he passed a 1% sales tax and dedicated it to healthcare. And he's giving over the next 30 years, some of those funds, majority of that 1% new sales tax, and it's been in there for 3 or 4 years, to healthcare development. So the way you build a new hospital is you partner with somebody that sees the economic impact on that city, and they're willing to invest with you the dollars to make that hospital sustainable over time. And you have to go through a long process in Alabama if you're going to do that. It's called a 772 constitutional process. And you have to have public hearings. And at every public hearing about what the city was going to do, the only thing they wanted to know is, when's the hospital going to be ready? And there was all positive. So you do that. And why did he do that? Well, this is his statements. It's not mine. He did it to foster quality healthcare services for the well-being of his citizens. He did it, this is interesting, he did it to increase the Thomasville tax base and tax revenues and promote economic development. Well, how does he think he's going to do that? Well, he got a $190 million plant that's going to create about 150 jobs here to come to his little city and buy 200 acres of property, put a $190 million investment in it. So he's creating economic development. And he knew that the expenditure of public funds for the development of this hospital and medical park, in conjunction with the developer, us, would serve a valid and sufficient public purpose, notwithstanding any incidental benefits accruing to the private entity. So you got to find that there are very few and hard to find that think that. Let's look at what we're doing for the mayor of Thomasville. Let's talk about Thomasville. Thomasville's 100 miles from everywhere, or nowhere. It's 100 miles from Montgomery. It's 100 miles from Mobile. It's 75 miles to Meridian, Mississippi. It's about 100 miles from Tuscaloosa. It's 140 to Birmingham. It's out in the middle of nowhere. Doesn't have an interstate, not even close. But what did he do? It has railroad tracks that run through it. Guess where he's getting all his industry? He goes and gets grants from the state of Alabama and the federal government to build railroad spurs and plants. That's the way he gets the plants in there. And it satisfies that customer. So he's used this for economic development by creating something he did not have and he lost in 2011. His hospital closed. Why did it? Do you think he had a sales tax then for health care? Do you think he invested a dime in health care? No. But now he knows that that's one of the economic drivers for his recruitment of business, and he's willing to do it. And so that's what we're doing. And what are we doing? We're building a hospital? Not really. We're building a whole medical park, because this mayor he doesn't want just a hospital, he wants a medical park. His dad, he took his dad to Mobile for radiation treatments for about a year. And he said that was a tough situation. Drive 100 miles to get your radiation treatment and stop several times coming back because the dad's sick. And there's no cancer care in that community. So he wants a freestanding cancer center at some point in time. We've got 40 acres of property that we work with him on. 40 acres. We don't need 40 acres of property. The hospital sits on 2.43 acres. But we've got 40 acres to develop other things around that help each other in the future. Senior living facilities in the back here. Whoop, I won't do that. Senior living facilities in the back. Future cancer center. And guess what? He just attracted the regional helicopter service for the Gulf Coast to come and base their operation and keep a helicopter in Thomasville, Alabama, all 24 hours a day, 7 days a week. So the reason they can't come, it's close to the Gulf, but they want to operate out of there. So if we have a bad accident or whatever in those plants or whatever, they get stabilized here, but the helicopter doesn't have to come 100 miles to pick them up. It's sitting right out back. So that's something we created. But what did we really build? We talked about the old inpatient days. This is the footprint of the hospital. There's very little inpatient beds. There's 29. But look at all the outpatient. Look at all the outpatient area over here. And why is that? That's the future. But we're building it once. We're not having to recreate it. But we're building outpatient services, diagnostic surgery, emergency services, women's diagnostics, occupational medicine, clinic for those plants that are there, physical rehab, family practice, walk-in clinic. And we're building it 2/3 or 3/4 of the hospital is all dedicated to outpatient care. And that's what it's about in the future. Now, if all those 48 rural hospitals could invest capital and work with their city and all to do that, that's the thing to do. But the best thing for all hospitals, including this one, is the Medicaid expansion, the wage index, getting that looked at and passed to protect Alabama and help Alabama in the future, and then all the other things we can do for preventive care, telemedicine, and using technology to make a difference in people's lives is what we need to do. Let me show you what this is about. This is our hospital, this front. And this is a design that has the doctor office building to the left and the hospital here to the right. And when you walk in the front door, this is what the hospital looks like. Now, it looks upscale, right? Well, we got a very large gift from a relationship that the mayor and we've had for many, many years. And this will be called somebody else's lobby. It's not ours. But they gave a lot of money, and so we've got a little nicer finishes there. And that's looking from the other side of the lobby. We have a chapel there. Now we're considering calling it a prayer room instead of a chapel to be more inclusive. Because I spent 32 years at St. Vincent's. I was not Catholic. I was the first non-Catholic CEO in 100 years to the day that the sisters got off the train down at the terminal station and founded St. Vincent's. So it was a chapel to me, even though I was Baptist. But prayer room, and it's right across from the emergency room. So we're putting that right there. It's really the tower to the right is the chapel. It's right in the front door. The rooms are gonna look like this. This is a patient room. What do you notice? Lots of light. Light makes a difference in care of patients. Much light makes a difference. They'll have blinds there, that blackout shades and so forth if you need those, but that's there. I could give you a live shot, but it may be late. There it was. That's a live shot, camera shot on that site right now at whatever time it is, 7:13 tonight. And you can see it's about 98% complete on the hospital side. And the sun sets in the west, so it's shining on that building right now, see. But that's a hospital we're building. And we've been given a blessed opportunity to be involved in this. Our family's involved in this. We've got a few business partners. But we've been given a blessed opportunity, and we've been supported by people that want to make a difference to their citizens. Leonette said there's 4,000 people in Thomasville. When we did a physician manpower study and looked at the 40 miles out around Thomasville, 35 miles out, 30 miles out, 40 miles out there, 80,000 population. Well, guess where they come to shop? The third super Walmart in Alabama. Where do you think it was built? Thomasville, Alabama. Wonder who was the Walmart manager then? Mayor Sheldon Day. Last 23 years he's been mayor. And so they come to shop, they come to eat, and they're gonna start coming for health care. We want to, in this study,
Where do they go now?
they go to Mobile. There's some other hospitals in Clarke County. There's 3 hospitals. They're all struggling. Grove Hill Hospital, city-owned hospital, Camden, Alabama, and Camden is in Wilcox County. But Grove Hill Hospital, Jackson Hospital, and and then the third one would be Thomasville in that same county. But if you look, again, about 35, 40 miles out, 80,000 population, we also will have space in that building for specialists to rotate. In the physician manpower study, we looked at what were the needs in that 42 zip code, that 40-mile area out. And Leonette, some of the things that you talked about, mental health was mentioned, but there were other things that we didn't think about. So we're trying to attract from Mobile, which is 100 miles out, Meridian, Mississippi is 75, Tuscaloosa is 90 to 100 miles, specialists to come and be in our new building here and be there to see patients 1 or 2 days a week. And we're trying to use the study we did with a group out of Louisville, Kentucky, to study that 40-mile radius and tell us what's happening to those people every day. What kind of care do they really need? Instead of just building something and thinking we're doing the right thing. So that's what we're doing. And I'll see if I can get back to where I was. Yep.
I suspect you're gonna have 1 or 2 questions.
All right, I'm through. Oh, one other thing. We are bucking the trend, guys. We're bucking the trend big time. We still got a lot to do, but we got help from the city and all, but someone came and wrote this article, and it's out there in AlabamaNewsCenter.com publications. It's called Power Grounds, and there's a group at Alabama Power. They send this out to 15,000 people. They pick a city, 1 city a year, and they just happen to pick Thomasville this year. And so there's a Thomasville article in this. I think we have a few copies of that, Jolene, somewhere over here. But it's called, they wrote the article, and when he listened to us, it said, "Bucking the Trend, hospital opens while others close nationwide." So we're doing something different, but we've got a partner, and we're proud of what we're doing, and I'll answer any questions you might have. Yes, ma'am.
Are there things that the Alabama Hospital Association could do to persuade our legislators to expand Medicaid?
You know, you go to their website, and they've got it all over there about expansion of Medicaid and the difference it would make. It's tremendous. They work every day. I know they work every day on that, but, and it, you know, it's closer than it was, But yeah, they have task forces, they have everything in the area to try to get that done, but it's tough.
Isn't it just dealing with Kay Ivey, the governor?
And Bill Marsh and.
It's probably a few other people, but that, yeah, you go to the top, yeah, you go to the top, but you can't consider, I mean, you can't continue to see, there were 55 hospitals in 2011, there are 48 now. 21 of those 48, they say, the national studies say they're in jeopardy. So you've got to expand it, and where Medicaid people live in the rural areas and in the urban areas too. So expanding it for 340,000, just, it makes common sense. But it's hard to get it legislated. Yes, okay, yes, sir. All right, sorry, yeah.
Is the 1% sales tax to make up for the deficit, and is that gonna make your facility at least break even or profit?
Yes, sir. The commitment was for the 1%, we get a certain amount of that for 30 years. And with it, we went and monetized that. In other words, went to the bank and monetized that, and that payment stream over 30 years is going to pay that debt. We don't have to pay that debt back. And quite frankly, that was a good portion of the project on the construction side. So we went and used that money, instead of borrowing money for construction, we went and used that revenue stream from the city for 30 years to get the money to build part of the facility. It's a great percentage.
So what about your operating deficit?
Well, we're building a $35 million hospital. We'll have $12 million worth of debt on it. That's pretty good. That's 65% equity involved in the hospital. There's not a rural hospital that I know that has that situation. We still got a lot of things to do to get this thing up and going. There's a lot of rules and regulations. There's a lot of other things we need to do. But because the city made it a priority for economic development and their citizens' health care, mainly, they are holding hands with us, partnering on this, the funding of this up front. So we've got a very large gift, about 10% of that number, one person that makes this work. We went to the Treasury Department and we did something called New Market Tax Credits, hardest thing I've ever done, and we got $3.8 million of free money. And guess where the people that invested in this? People go to the Treasury Department and get they get credits, new market tax credits. Banks buy new market tax credits because they can buy them for less and they get to offset some of their investment income. But we got a group out of Arizona that came to Thomasville, Alabama, and they put $8 million worth of credits in the deal. A group out of Louisiana that put $8 million worth of credits. And a group out of New York that put $8 million worth of credits. Now those credits convert to dollars. That's not 24. It's 24 million credits. But we end up with about 3.8 million of money we don't have to pay back. We get it forgiven in 7 years. And the reason, it was a rural situation, and that census tract qualified for that program from the federal government. But very few people take advantage of it in healthcare. We work with a group out of Portland, Oregon, to help us do that. But there was a group in Alabama that had money, but we couldn't work with them.
Are you also in an opportunity zone?
No, sir, we're not. We missed the opportunity zone, and the new market tax credit, it went away in October 31, and we closed on that money October 31, so it's gone now. Otherwise, we would have qualified, but guess what? They changed the rules on new market tax credits, and if you're in a new market tax credit census tract, the governor's gonna probably put you in an opportunity zone. But in our case, we lost that opportunity because one reason we lost it was because the mayor's doing such a great job with economic development, it went away. You were gonna ask something? Yes, sir.
This presentation.
Yes, sir.
Could you get Mac McCutcheon and Del Marsh and the governor to sit and listen to this presentation? It would.
Well, they've probably been presented before, but I can talk to my mayor friend, and he probably could get us. They know this,
I know you know it,
but
But it makes a difference when a successful
Yes.
businessman tells them.
Well, that's true.
that this is the way to go.
Well, that's
Not
true.
some do-gooder.
Well, that's
trying
true.
to-
That's true. We'll see what we can do there. Mayor, again, the state of Alabama got, we had a water and sewer grant from the state of Alabama that was approved. The mayor got it. It was for $524,000. And we had to do a 20% match, so we had to put 100 down to that. But that, and he's also got an EDA grant for 1.2 million that's coming. So he knows the governor. We'll see what we can do to talk to him about this. Because it'll help, look, if he knows it helps something too for his citizens to get coverage that don't have those jobs out there, good suggestion. I'll talk to the mayor about that. Yes, ma'am.
Are there any entities in the state
Yes, ma'am.
that are pushing other mayors and local, they don't all have rail lines perhaps,
No,
but,
no, they don't.
but there obviously must be some other,
There's an economic
cities
driver in
and
those
cities.
in those communities. They're just not probably using them to the extent that they may need to. Or we got contacted somewhere in Sumter County. They were wanting to pass a tax like this, and they called it the Thomasville plan. Now, but however, that didn't work because the people looking at it, they wanted to be one of these critical access hospitals. They think being critical access hospital, if you get Medicare to pay you cost plus a little margin, is better to do. But they couldn't get a hospital that's been there 100 and something years to close that had just a few patients in Sumter County. So when that was found out, they dropped the plan, even though the citizens passed the sales tax to support healthcare development. But because one hospital wouldn't close or become a part of something larger, it's mainly coming from heart. They didn't want to give that up, so that failed. But good idea. Yes, ma'am.
If you said this, I apologize. Are you offering obstetrics?
No, ma'am.
So the hospital in Grove Hill still has obstetrics?
They have obstetrics, and I can tell you why we're not. I can tell you St. Vincent's delivered 3,800 to 4,000 babies a year. More than 24. I remember the day we had 25 babies in 24 hours. With that kind of volume, you get the kind of physicians that know how to take care of high-risk pregnancy and everything in between. You get the most care for your women. In a situation there, we knew this other hospital was doing that. That was one of their major services, so we just decided not to get involved in that. We didn't think it was fair to the patient, actually, for us to do that because there's so few, and to attract the type of quality physician you need in OB, we just didn't think we could do it.
Well, and they're high risk of going to Mobile.
Well,
So,
just about everybody's going up to Mobile
I
too.
mean, they're driving hour, 2 hours.
Yes, ma'am. And I will say, I think it's been in paper down there, Clarke County Democrat. That OB program's not, the board is about to close. We understand. The rumor is, I shouldn't say that, but the rumor is they may not.
The Grove Hill.
Yes, ma'am.
So
And that's
with-
gonna be sad. But,
Well, it sounds to me, I was born in Grove Hill.
oh, how about that?
So how about that?
How about that?
But it sounds to me that Grove Hill Hospital, all those patients are gonna migrate your way. They're what, 20-minute drive from Grove
Yes,
Hill
ma'am.
to the hospital?
Yes, ma'am. It's about 20 minutes. But I will tell you, when there was Southwest Alabama Hospital there in Thomasville, it closed in 2011. There were 3 hospitals there. You had Jackson, Grove Hill, and Thomasville. They all drew from different markets. They didn't cross lap. It was kind of interesting. Thomasville drew from Marengo, Linden, Demopolis, in that area up. Grove Hill, of course, didn't. They didn't drive by Thomasville, and vice versa. The Grove Hill people didn't drive that way. So it all worked. But that was when reimbursements maybe been better. But today it's hard to make that all work. One of the doctors at St. Vincent, Dr. Rex Harris, he grew up in Grove Hill years and years and years ago. He went back down to this hospital. That's the way we got involved. He called me one day and said, "Can you come help this hospital, build a new one?" And we tried that, but it just didn't work because there was no support locally or anywhere else. And until it's tough. But we don't want to. We want to be cooperative. Work with Grove Hill. Work with Jackson. The Jackson CEO came up, I think, visited with Mayor not long ago and toured the hospital. Let's be cooperative. That's what we're doing. Same thing with Camden and Wilcox County. We visited with that board. They said, "Hey, we'll work with you in any way we can." Some of that needs to change as far as like Camden. They were about to close. UAB got involved, I think, and there needs to be something urgent care diagnostic there, not an inpatient hospital. They still have air conditioners there in Camden. But good question.
But you hit the nail on the head too, people can't drive. Transportation's a major issue.
Transportation's a major issue, and I didn't bring that up, but it was one of the things that kept coming up, that transportation is a major, major issue. And also, we just didn't get involved in OB because they were doing it. Not to say that we won't in the future, but it's just, I personally think it's not fair to the people you're treating. I don't think they do any more than a couple of hundred a year. That's not good. But, yes, ma'am.
The situation with hospital availability in Greene County, what do you think, how can that be addressed?
Yeah, that one's tough. I don't know all about the particular situation there. They're probably without a hospital now. They're without a hospital. That one's tough. It is close to some of the other major cities, I guess, Tuscaloosa, I guess. But that's still a drive and all. There needs to be a new model, and that's what we need to do. I don't know what that is.
Speaking of non-traditional,
Yes.
talk to us about midwives.
Oh,
What
I
kind
don't
of
know
role
about-
they might have.
Well, let's even go back to clinical nurse practitioners first. Certified clinical nurse practitioners. In the state of Mississippi, they can do anything a doctor can do. In the state of Mississippi, they can do that. In Alabama, they can't.
No,
So we're hiring some clinical nurse practitioners that will be in the walk-in clinic, do occupational medicine. But there's certain things they got to have a doctor sign off on that they just can't do, which doesn't make any sense. But it's the folks that got control of that from that just don't let it happen. Midwives is, I don't know, it's probably the same way. I just don't know that much about it on that end. But all the rules need to be lifted to take care of people. And a clinical nurse practitioner, there's some I know in Thomasville in some of these practices that we met with the other night, and they came and toured the hospital. The patients call up there and say, "Hey, is the clinical nurse practitioner in today?" They don't ask for the doctor. And if that person is in, that's where they're going, because they're in 4 locations, different locations, they rotate, and the doctor rotates. So, much needed, I would say, can make a difference in situations like what you're talking about, but I don't know much about that, sorry. But it's just like, again, the clinical nurse practitioners need to be in
I
change.
think we eventually need a women's center soon. don't you think?
Yeah, we'll have women's diagnostics, we will have the,
I'm on that. bandwagon.
yeah, we're gonna have women's diagnostics and,
women's center.
the one of the
It'll be
3D
a while, but.
mammography deals there. We have bone density, we'll have ultrasound. So we've got a women's diagnostics area. We just don't do OB, I'll say yet.
Yeah.
I could see a link between South, you know, them even sending somebody maternal fetal
That's
guy
right.
up there to you guys.
Well, see, that's the answer right there. I think that's the answer. And we want to do some GYN stuff, surgery. We have a surgery wing and endoscopic work and all of that. We have 2 endoscopic rooms and two general surgery rooms. We want to do all of that. Thank you.
Jean has live streamed this tonight on our Facebook site, and Curtis has generously agreed to post much of his presentation. We will have access to that. There will be an article in the Voter about the provocative statistics he's left us with tonight. And I just want to tell Curtis and Jolene how much we appreciate their coming. You have no idea what kind of schedule they have to make this hospital happen and his other international commitments that he has. So thank you again, and we hope that we will stay in touch, and maybe we can get invited to the grand opening of the Thomasville Hospital.
You're all invited.
It'd probably be mid-November or maybe mid-December.
Road trip, that's what I'm saying.
Road trip, 140-mile road trip.
Thank you all
I'm
for
gonna
coming.
say this, we've gotta have a good, bulldog mayor, and he is
He sounds like
He
he's
is
amazing.
forward
He
thinking
is forward
and
thinking.
always, you know, oh, let's do this, you know, anything he hears, and then you've gotta have a stubborn man that's fighting for it. And also Thomasville is a praying community. I tell you what, they have prayed that hospital, everybody, so.
Yeah, this is a God thing.
I mean, this is, it's a community wanting it to. So,
What's their main industry? What's their main industry there?
Wood products, they have, there's a company called LP, Louisiana Pacific, that is, I think either the first, I think they're the number 2, maybe even number 1, producer of a certain type of plywood in the whole country. They have a company from China called Golden Dragon Copper Tube, $100 million investment by this group. They make copper tubing in all the commercial air conditioners. They are the world's largest manufacturer of copper tube in the world. They have 8 plants in China, 1 in New Mexico, and 1 in Thomasville, Alabama. And he competed against Dallas, Texas, and Little Rock, Arkansas. Why Little Rock, Arkansas? Well, when Bill Clinton was governor, Bill Clinton named one of the cities a sister city to Hunan City in China. Hunan, Arkansas, Hunan. And that was because they wanted to go look at that. And Clinton called the chairman of Golden Dragon to try to convince him to come to Little Rock, Arkansas, and the mayor down there, you know what he did? He tells a story that when the Chinese came in to make their final decision, I don't know if they kept going back for dessert. That was banana pudding. So he says that's the real reason they came to Thomasville. Didn't have anything that he did.
they did like the banana pudding, that evidently they'd never had it.
They never had it.
So, I will tell you, those ladies in Thomasville made banana pudding like you wouldn't believe it.
But then he also had this $190 million, it was Westerfeld from Tuscaloosa. They didn't have to build this thing in Thomasville. They're taking 200 acres of property, the mayor showed me the other day, 200 acres, and it'll take them to 2021 to finish the sawmill. But that sawmill's gonna sit on 125 of those 200 acres. It's massive. He's got approved from FAA a rural airport in Thomasville, Alabama, with a 4,000 population.
He's a go-getter.
He built a $26 million water system for Thomasville. He got $13 million from Senator Shelby's office and other federal grants. It took him a long time to get all that done, but he's persistent and he's a great partner. He's in DC right now. I talked to him today.
Is he a full-time mayor or is he still working at Walmart?
He's a
No, he's full-time mayor. He can tell you a story about that, but I won't tell you about Walmart.
Let him tell you
About
about
Sam Walton.
Yeah.
But there's an Armstrong wood product there that's either one or two in the country. So you go to Thomasville and you're gonna pass these big log trucks or stay behind them for a long time because it's a two-lane road for the most part. But he's used those products, those wood products and those plants to create industries that thrive. And he's got another very big deal about Heitman, maybe, that he's competing for. But he's just a competitor. I mean, he just competes.
And he offers,
He makes it
solutions.
happen.
He's the, okay, well, you need the railroad to go in there, and you need this, you've just gotta have somebody that's innovative, a politician that cares about the town,
Yeah.
and not about what he's making, and that gets in there and actually does what they need.
And the Portomobile is, again, also 100 miles away. So that comes into play on some of the things that he's doing. If he can deliver that through rail or trucks down to Mobile, he can compete for industry.
What is his name again?
Mayor Sheldon Day. Day, D-A-Y. Mayor Sheldon
Has he
Day.
thought about statewide office? We need a little innovation.
He tried that one time. He ran for senator and lost by 17 votes or something. But he could do anything he wants to do, and he's in D.C. right now. He's in D.C. for the next 3 days. He goes up there about once a month, and he's up anyway. He could do anything. He's great. He's great guy. Great partner. Thank
Thank you very much for
Yes, ma'am. Thank you.
joining. And it's really great for the Daniel Payne Plaza to let us use the facility tonight. So as we close, I just want to recognize Reverend Jermaine Richardson and ask him if he has any closing comments.
Nothing more than to say we welcome you here. We're glad to have you here. I had no real responsibility to be here other than the person who does the building management is at a men's retreat this week. And so I stepped in to make sure that you all were accommodated well. And I got a wealth of information. I'm glad that I was able to be here and sit in. And Mama Ida, as we call her in the church, handed me a card. And I'm going to fill it out and give it back to you so that I can be apprised of other events like this. And anytime you want to come and meet here at the plaza, we are glad to have you.
Thank you
Thank
so
you.
much.
Thank you.
Everybody have a good night, and remember, it's September 12th, 5:30 to 7:30 at City Club. Meet and greet. Thank you.
Thank you.
And we have some copies of the article, if you would like one of them.